So I'm Gabriella Ricciardi. And
This meeting is being recorded.
oh, sorry. So, and I'm currently working at Lille University Hospital Center. You can see it. You can see the geographic position here on this slide. So we are in the north of the France, and this is a Ross Center. So I have no disclosure to declare, but of course I'm really interested in Ross procedure, and this is one of the reasons why I particularly chose this article to present to you. And I'm glad Dr. Mazin could join us because I think this will give a lot to the discussion of this paper. So, just to start, a quick but yet important, at least in my opinion, introduction, why are still discussing today which is the best substitute for aortic valve surgeries. This is, of course, because we have an unsolved problem, so that one of the optimal valve surgeries. In fact, an ideal valve substitute would be as appropriate valve, should be non-thrombogenic, should not require any anticoagulation, shouldn't have excellent hemodynamics with no gradient across the valve, should be easily implantable and readily available, and of course, but this is really a dream, should have the ability to regenerate on its own, and it's crystal clear that such a substitute doesn't exist. And actually here comes Donna Ross, who realized this problem well before us and start thinking about a good solution to address this issue. Here you can read his own words. So he stated that since God created the aortic root as non-thrombogenic and non-obstructive anatomic units, the relationship between its morphology and function should be maintained to allow an unimpeded physiological blood flow. But he didn't come to this conclusion out of the blue. But as we can see from his publications, he actually progressed over time just to finally arrive to the publication of his own technique. In fact, as you can see in this nice sketch, he first tried to demonstrate the advantages of mechanical versus biological valves, then moved further and further to the use of homograft valvular substitutes, and then he finally came up with his own technique, which was published on the Lancet Journal in 1967, and as of course the name of Ross procedure. So why should we propose a Ross procedure to a patient? Of course, as we said before, the ideal valve substitute doesn't exist. So for each of the valve that we can use today, both advantages and limitations exist. And of course, Ross procedure doesn't escape this issue. So as you can see in this nice review, which was published by Chauvet and colleagues on structural heart in 2021, potential advantages of Ross procedures include excellent long-term survival, superior hemodynamics, which are of course associated with better quality of life, and a potential low rate on of valve-related complication. This at the price of potential technical complexity, failure of the two valves, because as we are going to see later, we are going to work also on the right side of the heart, and technically challenging reinterventions. So, according to the American guidelines, the best candidate to Ross procedure is a young patient with appropriate anatomy and tissue characteristics for who anticoagulation is either contraindicated or undesirable, and should be performed at comprehensive valve centers by surgeons with a large experience in this procedure and in general in aortic surgery. Surprisingly, there's no room for Ross procedure in the European guidelines. But just referring again to a paper published by Dr. Mazin on Journal of American College Cardiology in 2018, we can use to propose the ROS procedure this algorithm, which was published by the authors. So according to this flow chart, the best candidate for ROS procedure is a young or middle-aged adult with unrepairable aortic valve disease, high levels of physical activity, or in case of women, patient contemplating pregnancy, and without familial orthopathy, connective tissue disorder, autoimmune disorder, and with a life expectancy which is at least more than 15 years. Of course, there are also ideal anatomic substrate for the ROS procedure, which are those with aortic valve stenosis and with a small or normal-sized aortic annulus. In this case, all the modifications of the ROS procedure which have been proposed during years can be applied, while in presence of a suboptimal anatomic substrate, which means that we are facing a valve which is regurgitant or which exhibits a mixed lesion with predominant insufficiency, which has a dilated annulus with a diameter more or equal to 27 millimeters, or a patient who has an aortic to pulmonary size mismatch more than 2 millimeters, well, in these cases, we can still propose the ROS procedure, but applying the modified ROS technique with autograft reinforcement is really recommended, regardless of the technique that we are going to choose. Aside postoperative blood pressure control, at least during the first 6 to 12 months after the procedure, is highly recommended too. But now back to the study, which is the focus of our talk. So the rationale of this study is that actually there's a paucity of comparative data between ROS procedure and bioprosthetic AVR. In fact, one of the most important study in this sense was the one published by Sharabiani and colleagues on JACC in June 2021, where the authors compared outcomes after AVR and ROS in the young using data from a national database, and concluded that all valves with good survival, with actually the lowest 12-year estimate being for mechanical AVR. This is also a nice graph that we can find in the article, which shows the dynamic change of risk mortality or intervention during follow-up period after aortic valve replacement operations by the procedure types and the age group. As you can see in the graph, risk of both mortality and reintervention, which is represented as overall cumulative risk, decreases with the patient age and increases during follow-up. The overall increase of risk differs depending on the AVR procedure type, and the speed of increase in risk during the various stages of follow-up time is not proportional across the AVR types. Actually, I added this slide yesterday because I found another nice article, which is also recent. It was published by LMMC and colleagues just in 2022, and this is another propensity matched comparison of the ROS procedure and prosthetic aortic valve replacement in adults, and the conclusions are actually the same. In fact, the authors state that at 15 years, the cumulative incidence of all-cause mortality, as you can see in the curves, is significantly lower after the ROS procedure compared with biological aortic valve replacement or mechanical aortic valve replacement. And we can see also that the bioprosthetic holds the better results than poorer results compared to the mechanical prosthesis. So back to the study again, the authors decide to realize a propensity match cohort study. So they compared ROS patients to bio-AVR patients, and they looked for long-term survival and adverse valve-related events in the two cohorts. So the study was realized collecting all the patients between 1990 and 2014. It was realized at Toronto General Hospital, therefore it's a single center study. And surprisingly, there was just a single surgeon for 97% of the ROS procedure and 60% of the bio-AVR procedure. So if we go deeply into the numbers, they collected at the beginning of the research more than 5,000 bio-AVR patients and more than 200 ROS patients. Of this, more than 4,000 were excluded because of their age, which was more than 60 years, and more than 200 were excluded for other reasons, including as you can see, endocarditis, dissection, urgent or emergent surgery, renal failure of dialysis, or or because receiving an aortic homograft. So they ended up with a total of 556 bio-AVR patients and 233 ROS patients, and they did a 1-to-1 propensity score matching, so that they finally ended with 108 patients in both groups. As you can see, they try to make the groups as comparable as possible. So the median age at surgery was 40. We had slightly prevalence of male gender in the bio-AVR, while if we look at the data regarding previous cardiac surgery, we can see that bio-AVR patients received previous cardiac surgery more frequently than ROS patients. If we take a look to the cardiovascular risk factors and to the associated conditions of the population, including COPD, previous stroke, atrial arrhythmias, complete heart block or pacemaker, or a low ejection fraction less than 40%, we can see that these are nicely distributed among the patients of the two cohorts, and this is actually the purpose of the propensity match analysis. Again, if we look at the symptoms of the patients included in the two cohorts, we can see that all the patients are nicely distributed for NIA class, while if we take a look to the aortic lesions, we can see that stenosis is a little bit more frequent in the bio-AVR group, while in the ROS group we have a slightly higher prevalence of insufficient and bicuspid aortic valve. So, speaking about surgical technique, in case of ROS, all the modifications were used. So, patient received modified subcoronary ROS procedure, aortic root inclusion technique, and freestanding neo-aortic root, while when we move to the biological prosthesis, the surgeon used both stented porcine bioprosthesis, stented pericardial bioprosthesis, and stentless porcine bioprosthesis. And I refer to a single surgeon because, as I said before, there was actually just one surgeon performing almost all the operations in both groups. The choice of the different ROS modification in this cohort was moved by three criteria: the pathology, the underlying pathology of the aortic root, the size of the aortic and pulmonary roots, and the anatomy of the coronary arteries. And where there was an aortic to pulmonary root mismatch more than 2 to 3 millimeters, actually the surgeon added a reduction of the aortic cannulus and/or sinotubular junction to the standard technique. So, which were the outcome the authors looked for? They analyzed death for any cause as a primary outcome, and they studied causes of early and late mortality and stratified death for any cause in valve-related, cardiac-related, and non-cardiac related death. And they looked also for secondary outcomes, including valve reintervention, valve deterioration, endocarditis, thromboembolic events, and finally pacemaker implantation. So in considering valve reintervention, both surgical or percutaneous reinterventions were taken into account. And for the Ross group, both reintervention on the pulmonary autograft and reintervention on the pulmonary homograft were considered. Speaking about valve deterioration, the authors looked for structural deterioration, non-structural deterioration, and endocarditis for this secondary outcome. Structural deterioration was described in terms of wear, calcification, tear, or recurrent or new aortic or pulmonic regurgitation or stenosis, while non-structural deterioration was described in terms of pannus, paravalvular leak, or aortic or pulmonic regurgitation due to technical errors or dilation of annulus and or sinotubular junction. So how did they perform the statistical analysis? As I said at the very beginning of the presentation of the study, they used a propensity score matching model. So they did a 1-to-1 matching of the populations using the choice of operation as a dependent variable and using as independent variables different factors, including, as you can see here in this chart, age at surgery, sex, here at surgery, weight, BSA, preoperative diabetes, congestive heart failure, angina, COPT, and so on. So if we look to the results, in the BioAVR group, it's clear that the most used prosthesis was the Hankook 2 porcine valve, and we had actually a slightly large size of the implanted prosthesis with the 27 millimeters as the most frequently implanted. And if we move to the Ross procedure, we can see that 63 patients, so 58% of this population received subcoronary or root inclusion technique, while 45 patients, so 42% of this cohort, received freestanding root population. Concomitant procedures were more frequent in the BioAVR group, especially ascending aorta replacement. So which were the main findings? If we take a look to the median cross-clamp time, median cardiopulmonary bypass time, pre-discharge ecography parameters, and especially patient prosthesis mismatch, it's clear that for all these parameters there was a statistically significant difference between the two groups. While if we move to in-hospital mortality or better in-hospital outcomes, median ventilatory support duration and median intensive care unit stay, there was no such an important and statistically significant difference between the two populations. So going forward, primary outcome, as I said before, was death for any cause. Mean follow-up was 14.5, more or less 7.2 years. And here the results. The authors found a total of 7 deaths in the Ross group versus 21 deaths in the BioAVR group. And if we look to the percentage of all-cause mortality all over the 20 years of the study, we have a percentage of 9.6% in the Ross population versus 25.1% in the BioAVR population. So if we stratify this primary outcome, we can see that in the valve-related group, we have just one patient dying, showing dying in the Ross group versus 16 patients dying in the BioAVR group. If we move to the non-cardiac causes of death, we have 60 patients in the ROS group versus 1 patient in the BioAVR group, and for all of these patients, the cause of non-cardiac death was late malignancy. So if we look again to the cumulative incidence of valve-related mortality in the propensity-matched cohort, it's crystal clear from the curve that the ROS procedure is superior to the BioAVR procedure. Again, look into the results. If we move to valve reintervention, we had a total of 15 reinterventions in 11 patients in the ROS group versus 37 reinterventions versus in 35 patients in the BioAVR group, and in most of the patients, the reintervention was performed surgically and less frequently percutaneously. In fact, on all the reoperated ROS patients, we have 12 surgical procedures versus 3 percutaneous procedures, while in the BioAVR group, we have 36 surgeries versus just 1 percutaneous procedure. Here you can see that the authors actually looked really deeply into the cause for ROS reinterventions. As we said before, they took into account both reinterventions on the pulmonary autograft and pulmonary homografts, and surprisingly, there was no operative mortality between the 11 reoperated patients, while in the AVR group, they had just 1 death. This was the case of a patient with a large aortic root abscess extended to the tricuspid valve and the left main coronary artery. So if we look at the results for valve deterioration, we can see that considering any valve deteriorations, there was a higher rate of deterioration in the BioAVR group, and this was again true with a statistically significant difference between the 2 groups if we consider structural valve deterioration. And these results remain stable also when we consider in the ROS group both deterioration of the pulmonary autograft and the pulmonary homograft. Again, talking about the secondary outcomes, if we look to the results of endocarditis, there were 4 events in the ROS group, 3 of which were addressed surgically and 1 with medical therapy, versus 5 events in the BioAVR group, again with 4 surgeries versus 1 medical therapy. Thromboembolic events were higher in the BioAVR group with 15 patients versus 9 patients in the ROS group. And lately, talking about the permanent pacemaker implantation, there were 16 patients at 20 years receiving a permanent pacemaker in the BioAVR group versus 4 patients receiving pacemaker in the ROS population. So here you can see that these results are nicely shown also in the curves. Here the curves for the endocarditis, here the curves for thromboembolic events, and here the curves for permanent pacemaker implantation. So it is rather clear that the conclusion of the authors is that ROS procedure is somehow superior to the BioAVR. So this is the conclusion somehow. But I think it's important to discuss how did the authors the authors came to this conclusion and to find a valid scientific support. So they say that the ROS procedure is superior to BioAVR because it holds a better long-term survival. This was actually already stated in the paper by Sharabiani and colleagues that we showed at the beginning of the presentation. But so far, this is the first paper with more than 12 years more than 20 years follow-up. Sorry. Better long-term survival is probably related to the better life expectancy of the ROS compared to the BioAVR, And actually, this is somehow in accord to another paper, which is the Swederhart study, which demonstrated that the survival in patients after aortic valve replacement compared with the expected survival of the age, sex, and calendar here matched the Swedish population is quite lower, and is probably also related to the better long-term outcomes compared to the bio-AVR, and this is actually in accord with the results of another paper from the same group, which was published on the JACC State-of-the-Art Review. Better long-term survival. Could this be a bias because we select better patients for the ROS procedure? Well, the authors mitigated this problem with one by one matching the two cohorts. So patients in both groups were young, healthy, and at low surgical risk. So we can definitely say that there's no bias in this sense. Why do we have better long-term survival? This is probably related to the lower rates of valve-related complication, and this is a consequence of the special properties of the autograft, which has better hemodynamic properties, special, we can say, biological properties, and shows no patient prosthesis mismatch compared to the bio-AVR. Here I show this paper because I found it really nice. It's work by Tori and colleagues. And what did the author do? They worked in the lab on volumetric flow rate waveforms for autografts, xenografts, homografts, and normal aortic valve. And we can see in the graph in the upper side and in the graph in the bottom side that the volumetric flow rate waveform of the autograft are really similar to those of the normal aortic valve. And this remains stable all along the cardiac cycle. So from its beginning to its end. Also, the authors looked to the shape of the normal aortic valve, autograft, homograft, and xenograft valves during the different phases of the cardiac cycle, and they showed that the valve, the orifice of the autograft valve is quite triangular in shape, which is really similar to the form of the normal aortic valve, and also that at the moment of the closure of the valve, the vertices of the valve are really close to the edge of the sinuses of Valsalva, while if we look to the homograft and xenograft valves, the shape of the orifice is quite far from a triangular shape, and also at the moment of closure of the valve closure, the vertices of the leaflets are not really close to the edge of the to the edges of the sinuses, suggesting that probably the valve doesn't completely close at this moment of the cardiac cycle. So, speaking about reintervention, again, the authors demonstrated the superior of the ROS procedure. So actually, they went again the misconcept that ROS could have problems in terms of potential failure of two valves and technically challenging reintervention, because they demonstrated that there is a low risk of reintervention even in patients with suboptimal anatomical substrates, because as we could see in the baseline characteristics, there were more insufficient and bicuspid valve in the ROS population, and also in the reintervention group, the authors didn't have operative mortality. So while then bioprosthesis ended up with just a second place. This was probably related with a higher risk of reintervention, and this is again probably a consequence of the low durability with a high probability of early reintervention. So the ultimate explanation for the low durability is the small size of the implanted valve, which is correlated with the rate of structural valve deterioration. We can say, in fact, that the smaller the implanted valve, the higher the risk of early structural valve deterioration, and so early reintervention. So the real problem of this substitute is the patient prosthesis mismatch. So also bioaortic valve prosthesis demonstrated a higher rate of adverse events. We had, in fact, a higher risk of reintervention for endocarditis, continuous hazard of thromboembolic complication, which along the 20 years represent a really cumulative lifetime risk, and they demonstrated a higher rates of pacemaker implantation. This is possibly related to the rigid nature of the sewing ring of the prosthesis. So which are the study limitations? They were actually highlighted by the authors themselves. First of all, this is an observational study, so it's a non-randomized analysis. Second, the propensity score matching tried to eliminate all the confounders, but of course can take into account the unmeasured and unmeasurable confounders. We have a small sample size, and also the authors didn't show any evaluation of the progression of transaortic gradients over time. Now, just a little bit of time from my observations. I really enjoyed the reading of this paper. As I said at the very beginning, I'm really interested in Ross procedure, and I firmly believe in the value of this technique. But I would like just to make a discussion with you about some points, especially preoperative versus postoperative pacemaker results, patient prosthesis mismatch, thromboembolic events, and reinterventions. First of all, I would like to discuss the results in terms of pacemaker implantation. In fact, as we can see in the preoperative data, there were already 2 patients with either complete heart block or pacemaker. This is not further explained by the authors in the Ross group, while at the end of the study, we ended up with 16 patients with a permanent pacemaker implantation in the BioAVR group versus 4 patients in the Ross group, but it's not clear where the 2 patients with already a pacemaker before surgery were included or not in these results. And I think in such a small population, this can somehow move the statistically significant difference between the population that the authors found. And also we can, looking to the curves, we can see that actually there's a risk of pacemaker implantation which continues to grow all over the 20 years of observation, meaning that the presence of a bioprosthesis remains a risk for pacemaker implantation for a long time after surgery. And I think this is a nice point to discuss. Looking to the patient prosthesis mismatch, we can see in this graph that the surgeon who performed the BioAVR replacement actually used slightly large prosthesis. The mean represented size was in fact 27 millimeters, but also with this, we ended up in the study with a moderate to severe patient prosthesis mismatch in the BioAVR group with a statistically significant difference between the 2 populations. So the presence of a large bioprosthesis doesn't eliminate the risk of patient prosthesis mismatch, and I think this is another good point for discussion. And just my personal opinion, I don't know if this data could be somehow influenced by the fact that for the ROS procedure, we somehow select a little bit the patient because we try to have an aortic to pulmonic root mismatch, which is less or equal to 2-3 millimeters, while for the BioAVR patients, we measure the real size of the aortic annulus just at time of surgery. Finally, talking about thromboembolic events, we can see that there's a really high rate of thromboembolic events all over the 20 years of the study. So the thromboembolic events represent a really important lifetime cumulative risk, and actually this results are in disagreement with results of another study which was published in 2019 by Papak and colleagues. The authors showed, in fact, that there was no significant difference between BioAVR patients receiving warfarin or aspirin alone and receiving aspirin or double antiplatelet therapy, but they are in accord with the results showed by Elamancy and colleagues recently. In fact, they found in this analysis that the cumulative incidence of stroke after mechanical aortic valve replacement is significantly higher than that observed after biological aortic valve replacement, but the incidence of stroke after biological aortic valve replacement is again superior to the risk for the ROS procedure. Just last observation, this is about our interventions. So we said that there was a single surgeon for almost all the ROS procedures and more than half of the BioAVR. My question is, there was just a single surgeon for all the interventions in both groups, because this change the mortality data that we have for interventions. And actually, just to highlight again the analogy between the two papers, also the group for LMNC found a lower risk of mortality during reintervention for ROS procedure. And just a quick talk, because I would like to discuss also our results in Lille, just to spread the discussion. So from January 1992, from August 2019, we did in this center more than 2,000 aortic root surgeries, including 510 ROS inclusion procedures. If we can look, if we take a look to our results in terms of interventions, we can see that all over our experience, we applied different ROS modifications, including full root replacement, Valsalva reinforcement, and subcoronary implantation. Because of these results, in fact, if we look to the table, there was a higher rate of interventions in patients who received the full root replacement. We have moved by years to use Valsalva inclusion in almost all the patients, and this is nicely shown also by the curves that you can see here in this graph. Again, talking about reinterventions, we also took into consideration reinterventions on the right side. As we can see in this graph, surprisingly, we had a higher rate of reoperations in the patient who received the pulmonary homograft at the time of the first surgery compared to the centreless bioprosthesis on the right side. And this is again nicely shown by the curves reported. So now I think I talked too much, and it's definitely time for your observations. Thank you for your attention.
Thank you, Gabriella. That was a very nice presentation. Can I have Dr. Sloan Guy for a comment on the entire presentation and in general, please?
Yes, good morning. Can you hear me okay?
Yeah.
Yeah.
Well, first of all, that was an exceptional presentation. with, remarkably good results over a long period of time from a group that has clearly mastered this operation. I think that there's many issues with the Ross procedure. I trained at the University of Pennsylvania with Joe Bavaria, and we were not big fans of it at that time, although I think they've started doing it since then. And I think the big concern at that time remains today in many centers, which is the reproducibility of that. In other words, I think in today's day and age, there are a few procedures that really cannot be done at every center by every surgeon and every surgical team. And it's my opinion, and this paper really supports that this is one of those procedures. Another example would be what I do, which is, endoscopic robotic mitral valve surgery. As much as I would like for every center to be able to do that, maybe they can't. The Ross has very important technical details that certainly most experienced root surgeons could do, but that doesn't necessarily mean that they should do it if they're not going to be doing it day in, day out. And I think that brings up the most important concern of mine, which is that historically, cardiac surgeons, because of the competitive nature of what we do, and of course, that may differ in different countries, but here in the United States, it's extremely competitive. Surgeons are generally not inclined to refer patients to another center unless it's a case that they really can't do some version of or don't want to do. So, in the case of the Ross procedure, there are acceptable alternatives like a standard, Bentall. And so I think there are a lot of patients that probably could benefit from the Ross procedure, particularly younger patients, but are not referred by the local cardiologist or local surgeon simply because they don't offer that. We know that surgeons generally don't offer procedures they don't do, unless it's a patient that they really don't want any part of and they don't have an acceptable alternative. So very similar to robotics or high volume mitral valve repair surgeon, some surgeon that does 5 a year, which we know has worse results, will go ahead and do that case because they want to do surgery. We all want to operate. So my feeling is that this paper demonstrates that there should be centers of excellence that do these. We all can't do it. If I see a patient in clinic next week that I think would benefit from the Ross procedure, I should refer that patient to a Ross center unless I'm willing to do the hard work to master that procedure and do it in relatively high volumes. So one question that I have for Gabriela is, what would those volumes be?
Sorry, can you ask your question again?
What level of volume would a surgeon and center do, in your opinion, in order to achieve the excellent results that your center has achieved? Where would the cutoff point be?
Yeah, I think that for this procedure, first of all, it's better to have a really large experience in the aortic root surgeries because you have to be prepared to a Ross failure. This can happen, and sometimes we do the perfect intervention and we ended up with a failure of the autograft in the OR, and we have to be prepared to address this issue, moving to another aortic root surgery. And I think, here, taking a look to the data of my chiefs, I think that they did at least 30, 40 patients for Ross procedure per year. So I think you should really train a lot to do this surgery nicely, because there are a lot of problems that you can encounter during the procedure itself.
Okay, so say you do that and you've mastered the operation. How many of these procedures per year should you do in order to maintain that level of proficiency, in your opinion? What's your best guess? I know we can't prove that, but for instance, in mitral valve surgery, Joanna Chikwi had a nice paper that showed the line somewhere around 25 a year. Where would that line be for the Ross procedure?
Well, I think for a surgeon in training, it should be 50 patients per year. Because
50 per year.
Yeah, I think you need to be really, really familiar with the technique and with modifications, because somehow we're forced to use one modification more than another one. And as I said before, I think the best is to be really trained before in aortic root surgery, meaning Pental procedures, Tyron-David procedures, and then probably move forward move further to Ross procedure.
Right. Okay. Would anyone else on the call have a different thought? She said 50, and it's interesting that you use that number, Gabriella, because I'm just going on my experience, which is mitral valve surgery, which I think is actually similar. The number in Joanna's paper is 25, but I feel like 50 is the more appropriate number. But the data really shows the inflection point at 25. So maybe I'm wrong about that. I think where we get into numbers, we do get into issues of competition and free market. And of course, I'm a big believer in the free market and allowing people to develop new programs. So I remember when Joe Bavaria talked about limiting TAVR based on volume a few years ago, right really after TAVR sort of come about. And I was sort of upset because I was at a competitor institution to Joe, and we couldn't get TAVR because we didn't meet these criteria. And I said, I think you're really trying to restrict us from being able to launch our program. What would have happened if they restricted your access to Prolene or to Dacron when you started the aortic program at Penn? And, that was kind of tongue in cheek, but I think there's two different things. Volume to start a program and then volume to maintain a program. And then also, I do think in our profession, we do need to change our attitude when it comes to when it comes to referring to our colleagues and admitting that, I may be an excellent root surgeon. I am a very good mitral valve surgeon, but, I've seen like one Ross procedure and I probably shouldn't, book one of those for next week, right? That's probably wrong of me. And it's probably also wrong of me to go do a mechanical root on that patient if they're a good candidate for a Ross procedure. I should, send them to Ismail or someone who does a lot of them. And so that's why I find this procedure so interesting, because it brings out those nuances of our profession and doing what's right for the patient, collegiality, competitiveness, technical supremacy for what is clearly a more difficult operation. Because there's no doubt that the larger centers have published results such that if I needed a root replacement tomorrow, I probably would want a Ross procedure. I'm 55 years old. I think I would be a good candidate for that. And I think that's the best chance that I would have of not having to have further surgery down the road. Would anyone disagree with that?
Yes, I would like to redirect the same question that you asked Dr. Sloan Guy to Gabriella, to Dr. Maral. What does she think? I mean, how many procedures does a center need to start the program to begin with, and then how many procedures that center should be doing to sort of maintain the technical adequacy of the program?
Yeah, these are really, really important questions. I really, I agree with what Sloan has said about actually doing what's best for the patient, even if it's not in your exact area of expertise. And I, for example, refer my mitrals, I'm not going to take a young patient with a complex Barlow's valve. I'm not a mitral surgeon. I will refer that patient, to someone who does expert mitral valve repair with no egos involved. And I think we really need to do more of that. There are data around the learning curve in ROS. There's a paper from Ismail's group and in Montreal Heart Institution actually showing his initial learning curve with the ROS procedure when he started the program in Montreal. And it's a good paper to read. You know, the results after the first 75 to 100 patients really improved. And it was mostly things like renal failure, you know, the clamp time gets better, acute renal injury gets better, all of the things. It's a long, complex operation that really does have a steep, in my mind, probably one of the steepest learning curves that we have. It's more steep of a learning curve than valve sparing route, for example, where you're the clamp time's shorter, and at the end of it, you only have one valve to worry about, not both the autograft and the homograft. So I think the initial learning curve takes about 75 to 100. That's what the data shows. But then afterwards, there's a certain volume to maintain. 50 ROS per year is a lot, Gabriella. Not a lot of centers in the US actually do that. In North America,
probably was a needle word, but
yeah,
I speak for myself because I'm a surgeon in training, so I would like to do 50 ROS. Yes, but
yeah, 50 is a lot for ROS per year for anybody. Amin is actually gathering the data. I'm going to let Amin comment on it. Amin's one of the residents in Toronto who's been dedicated to the ROS procedure and is really an expert in the ROS procedure, has published a lot of our papers out of Toronto and also worked with Ismail and the Montreal group. So, and we're looking now in North America with STS data to see what the volumes are per center and what that looks like in North America. But in Toronto, for example, Tyrone obviously was the one who did most of those ROS cases in the publications. We are looking to update that with the newer surgeons who are now doing ROS. He never did more than 20 to 25 per year, and it's gone up and down. But I do think you need a high volume of elective root surgery and of root surgery in general. Valve sparing root, Bentals, and ROS, and probably for ROS, the numbers somewhere around 25 to 30 per year, I think. But again, that's in terms of maintenance after the initial learning curve. Amin, do you want to comment?
Yes, first of all, thank you for the invitation. I really enjoyed how thorough Gabriella's review of the data were. I echo the sentiments that were expressed both by Dr. Zunyan and Dr. Guy. I think that it's a steep learning curve. You need about 75 to 100 cases to overcome it. And then after that, at a minimum, the data suggests that you would need 15 cases per year, in addition to a high volume of aortic root surgery. So if you combine, 40, 50 cases of valve sparing a year with 15 cases of ROSs, I think that's a bare minimum to maintain technical competence. And the ideal number is probably closer to 30 a year. And Gabriella, in your presentation, you had raised a number of questions towards the end. I don't know if we're going to circle back to that at some point.
Yes, I think we are going to circle back to that. I think, in fact, we should start there, and then we'll come back to some of the basic questions that might have. So the first question Gabriella raised was regarding the permanent pacemakers, if I'm not wrong, Gabriella.
Yeah. This was about this first because I saw the preoperative data versus the postoperative data, and I didn't really get if the two patients with a already implanted pacemaker were included into the results, because we are talking about a small sample size population. So I think this can somehow move the results that you found. And the second thing I would like to discuss, because I was surprised by this, I expected to find a high risk of pacemaker implantation soon after surgery, but in your graph, actually, we can see that this risk remains stable, and then actually it grows over time, 20 years, and I found this really, really surprising. So I would like to ask your opinion about this, because I think it's important also for learning surgeons to understand why do you found this result.
Yeah, so it's a good question. We did actually look at these data in detail. So to answer the first question, the 2 patients in the Ross group who had a perioperative pacemaker were included in that long-term graph. And they were basically the only patients in our cohort who had a permanent pacemaker implantation. So after the initial perioperative period, there were no pacemaker implantations in the Ross group. That's the first thing. The second thing with respect to the bioprosthetic AVR group, you're right, it's an interesting observation. I went back in the charts and saw the patients who had pacemaker implantation at follow-up to see what was the cause. And the majority of them actually had pacemaker implantation at the reoperation. So redo AVR, that's when most, but not all, but most of those pacemaker implantations happened. And for the remaining, although we don't have any direct evidence of this, I think it's probably related to simply ventricular health and maybe chronic compression on the conduction tissue that might have prompted those late pacemaker implantations.
Okay. And then my second question was about patient prosthesis mismatch, because looking into your data, actually you implanted really large valve. 27 was the most represented, so it's quite large valve. But the data on patient prosthesis mismatch are disappointing in the sense, because even with a large valve, we ended up with a patient prosthesis mismatch. So I would like to know, how could you explain this data?
Yeah, I can tackle that as well, unless Dr. Zunian wanted to take a stab at it. But so you're right, actually. It was an interesting observation, one of the more interesting observations, I think, in our study, which has also prompted some additional investigations on our end. So the first thing to notice is that, as you said, we implanted large prostheses in this BioAVR cohort. And that really reflects our group's philosophy that whenever possible, we implant the largest possible valves, and we use root enlargement techniques pretty liberally. Despite that, we saw relatively high rates of patient prosthesis mismatch and high gradients in the BioAVR. So that tells us a couple of things. The first is that regardless of how much you try to implant a large prosthesis, bioprosthetic valves are by definition obstructive, because you have a sewing cuff inside the lumen. So even if whatever you do, you will have some degree of obstruction. That's the first thing. The second thing is with respect to the gradients. So there's 2 components. There's the first component, which is obviously the restriction of the lumen, but also we know that the sewing ring of the prosthesis fixes the annulus in place and really eliminates that natural sort of distensibility and mobility of the root, which plays an important role throughout the cardiac cycle in maintaining optimal hemodynamics. So these 2 factors combined result in suboptimal hemodynamics in bioprosthetic AVR, despite an attempt to implant the largest possible valves. And we are now in the process of studying what's the impact, the long-term impact of these suboptimal hemodynamic factors on survival and heart outcomes in these patients.
I think Amin's point, Gabriela, you really narrowed in on some 2 of the most interesting findings in our paper. I would say, like, the great job in noticing those things. The pacemaker rate is really, I think it's quite important, and the fact that it continued to be a problem, and in Ross it's just not a problem, and in BioAVR it is a problem. I think this is actually quite important. And despite, so we are we do root enlargement about 25 to 30% of the time with just surgical AVR at our center. So it is fairly liberal, and we got large valves, but the mean gradient leaving the hospital is 14 in the BioAVR group, despite very large valves, compared to 6 in the Ross group. And the Ross just has without the stents, there's just no natural, like, it's just non-obstructive, whereas all of the stented solutions are obstructive. And so in fact, you know, a stentless root replacement is probably on the BioAVR side the only way to really have sort of good hemodynamics with a stentless full root. We reserve that operation for older patients. You know, doing TAVI in those like a porcine freestyle root is not that straightforward, and they calcify. So we reserve this in the older group. But Ross is really the only option to really have very good hemodynamics. And we do think that in the long run, the repeated injury on the ventricle of having slightly obstructive valves, and then, you know, people let the AI and the AS kind of progress with the bioprosthetic valve. They're not going to have the redo unless it's really quite bad and there's an injury to the heart. There's some cost to the heart muscle over time before they get to their redo. And we suspect that that is why we're seeing the difference in outcome long term.
And actually, but I'm probably wrong saying this, but I think that somehow ROS patients are a little bit more selected, let me use this term, just because when we see actually there's a mismatch between the aortic and the pulmonic root, we decide not to perform ROS procedure probably, while when we go straight for AVR procedure, we just measure the annulus at the moment of surgery. We sometimes have data about the annulus size from the preoperative echo, but this is not always really fitting to the reality. So I think this could be maybe another reason for this difference in the two cohorts. But I don't know if I'm right about this.
No, you're right. And you know, you said there was no more bias because we had matched the groups, but certainly there is still some residual bias. We offer ROS to patients who are young, who are healthy, no coronary disease, good ventricles, who we think are going to survive. You know, we think we can get them back to a very good life expectancy, and the curves separate early. And so that early separation shows that there's still some residual bias in our cohort. There will not be a randomized trial of ROS compared to AVR. That trial has been tried. It's been under, you know, it was funded. It was attempted to be rolled out, led by a PI in Hamilton, Dr. Whitlock, but very low recruitment and really sort of unable to do that trial. So we have to essentially live with the observational data and try to make those adjustments as best as possible, the way Amin has in his paper.
And the other question I had was about reinterventions, because this was a really surprising data for me that there was just one surgeon performing almost all the procedures in both groups. And I supposed that there was one surgeon, especially for reinterventions on ROS patients. So I asked myself if this couldn't somehow alter the results, because maybe there are many surgeons performing reinterventions on BioAVR patients, but there's just one surgeon who is probably the most experienced one performing the reinterventions on ROS patients, because these are supposed to be more complex reoperations. So I would like to ask that to you, if there was just like that, or it was just my supposition.
No, it's true. And the data is now being updated up to 2022 with more surgeons. You know, now it used to be only Dr. David predominantly doing these operations in Toronto, and now our congenital surgeons, of course, do them. And now, you know, I do them, and one of our younger surgeons, Jennifer Chung, also does ROS. So the data is getting updated to include everyone, but it was quite selective. And that's always the one of the issues with valve sparing root, ROS procedure, complex mitral valve repairs, the expertise of the surgeon involved, and then the generalizability of those results to everyone else is always, we won't solve that issue today in the webinar, but this is
yeah, I expected this, but just to be sure, I would like to discuss this with you. And finally, was surprised by the results on thromboembolic events, because I expected this for mechanical valves, but actually to find such a high rate of thromboembolic events in biological valves is really, really surprising. So I would like to ask, which is your medical therapy after bio-AVR, and if this is somehow correlated with your results, or which is your personal explanation for these results?
Yeah, so I don't think the rates of thromboembolism in the bioprosthetic AVR group are that high. It's 1% per patient year, which is pretty consistent with what is reported elsewhere in the literature. It's just that it's a cumulative risk. So by 20 years, it's 20%. It seems like a lot, but in fact, 1% patient year is pretty consistent with what sort of good, thorough studies investigating thromboembolic complications have reported. I think in mechanical valves, it's probably closer to 3 to 4% per patient year, if you look at prospective data, especially in the context of randomized trials, actually. So that's one thing. In terms of our postoperative anticoagulation or antithrombotic management for bioprosthetic AVR, I think it's changed a little bit over the years, and maybe Dr. Zunyan can comment more on that. I think we usually anticoagulate for the first 3 months or so, and then switch the patients to aspirin only. I don't know if that's always been the case throughout the course of the 20 years of this study.
It's changed. It certainly has changed over time, and it was more just aspirin only, and then now several of the surgeons do anticoagulate for 3 months in a bio AVR, but there aren't strong data to support that recommendation, so the practice is actually quite variable still.
Yeah, it was just also to compare to our practice, because we usually prescribe aspirin to bio-AVR. We move to anticoagulation just if there's a concomitant atrial arrhythmia, and we use aspirin also in ROS patients. So I don't know, just to make a comparison between the centers' experiences.
Yeah, quite similar. We do aspirin in our ROS patients also, and very strict blood pressure control when they go home. Yeah.
Yeah. Perfect. Thank you for your answers. I don't know if someone else has any other question. I'll just take a look to the discussion if someone asked questions. What was your cross-clamp time in ROS? I think this is more a question for Dr. Medin and Dr. Ozanian. They asked about the average cross-clamp time in ROS.
Well, in the paper, I think it's around 125, 130 minutes, something like that. Dr. David's a very fast surgeon. My clamp times are longer. They're usually, between 2.5 hours and sometimes up to 3 hours. It's not, especially when you're in the early stages of ROS experience, it's, I would say, closer to 3 hours, and you can get it down closer to 2.5. And then if you're Dr. David, it can be 2. Yeah.
And just one last question. What is your preference on the right side? So do you use allografts in all patients, or do you use also stentless bioprosthesis? Because here we are moving a little bit more to bioprosthesis. So we are using more and more bioprosthesis also in younger patients, but it's just to discuss about it.
What kind, Gabriella? What bioprosthesis on the right side? Freestyle?
Yeah.
Yeah. We have tried to stick with homografts on the right side, and homograft supply issues globally is a problem for sure. And we have trouble getting, we try to put the largest homograph that we can implant on the right side, at least a 27, 28. We prefer 28 or bigger, but to be honest, the last 4 I've done, there's been like supply shortages in the last few months that are even worse now. We use all of the companies that supply homographs. We use the local biobank at Sick Kids with local tissue bank that we have in Toronto and with valves from across Ontario, and we still have supply issues. So this is a challenge, and I was interested to see your results on Freestyle on the right. I must say we've stuck to homograph so far. Yeah.
Okay. Thank you.
Any other questions from anybody?
I'm going to take a look to discussion again, but I don't think we have.
I don't think any other questions are there. And Gabriela basically covered a lot of the questions that I had. You basically had everything in your presentation, so I'm limited to that. I won't have any further questions.
Thank you.
Dr. Guy?
You may be busy. Gabriela, you did a fantastic job with the presentation. We really enjoyed the discussion. Thank you so much for having me and Amin on the webinar. Hi, Sloan.
Hey guys, I'm sorry I had to step out for a minute because I'm in the midst of moving here to Georgia. But that was really a great presentation. I enjoyed it, and I look forward to more in the future. Thank you.
Okay, for sure. Thank you, everyone.
Yeah.
Thanks, everybody. Great to see
Thank
you.
you, Dr. Amin, for being here, for accepting my invitation and joining us.
Yeah, it was.
We hope we did some justice to the paper and we had some good discussion. We hope we have you back again sometime very soon.
Yeah.
Anytime. Thanks for having us. Okay.
So much.
Thank you very much.
Bye. Bye, everyone. Thank you.